Welcome to Spine and Wine Fall of 2024. Thank you so much for being here. It is also World Spine Day, so we are really excited to celebrate World Spine Day with all of our trusted, wonderful referral sources. So thank you guys for being great partners of ours. Um, our physicians at the Center for Spine and Orthopedics welcome you to tonight's virtual CME Spine and Wine. My name is Jenna Minetti. I'm the marketing director at CSO. And as many of you guys know, we've expanded our service offerings this year to continue our pursuit of being a center for excellence for spine and orthopedic care in our community. And our CMEs are one way that we continue to provide that, especially for our wonderful referral sources. We're very happy to provide this continuing medical education series. We do various topics on spine, orthopedics, and pain management topics. So we hope you enjoy tonight's topic on disc herniations. When do they matter? Tonight, we will begin with a wine tasting led by Dr. Kevin Downs. The wine tasting will be followed by Dr. Kershen from Health Images. He's going to lead us in helping us to better understand the appropriate imaging to order for patients with disc herniations. After that, Dr. Rumley will be our main presenter, presenting on disc herniations. When do they matter? I feel like I have to do this every time now. And then at the end of Dr. Rumley's lecture, we will have brief presentations by other of our provider team. We want to make sure that you all get to know our entire center of excellence. So we will have a short presentation from Dr. Leo on the pain management side, Dr. Cowin on the chiropractic care side, and Dr. Patrick Cook on the physical therapy perspective. So let's go ahead and get started. It's my pleasure to introduce Dr. Kevin Downs, a sommelier, the exciting part, right? He will lead our wine tasting. Dr. Downs is a retired OBGYN physician who specializes in fertility. He is also a former event planner at Watts Wet Goods in Longmont. Kevin became interested in wine during his years as a physician. I'm sure you guys can all relate. So please welcome Dr. Kevin Downs.
Good evening. How is everybody tonight? We are tonight talking about a wine. Actually a wine company that's kind of interesting. I chose them because they have a really interesting story. This is from 90 plus sellers. And the reason it's called 90 plus sellers is this group has a really interesting thing that they do. They basically travel the world and they look at estates throughout the world that have made very good wines and in fact have received at least 90 on the ratings board for various publications. So they have a history of being really good producers. As most wineries go, as most vineyards go, they make more wine than they can possibly use. So they really like to sell their wine if they can. And what this group does is they carefully look at wineries and they look at their grapes, they look at their wines they produce, and they buy their excess wine, and they're able to buy it at really reduced prices. They sign a contract with a winery that they will not tell anyone where they're getting their wine from because no winery wants to bottle their wine for $15 and have somebody else sell the exact same thing for $10. So it's all kind of this really cool. We don't know where the wine really comes from, but we know it's really good. And other people have tried this before and it failed miserably for various reasons, but this company has done very well. They've been around since about 2009, and they continue to produce fantastic wines. Tonight's example, this is a little Côte de Rhône. Côte de Rhône is a wine region in southern France. Basically, it stretches from just south of Lyon down towards the Riviera. This is an area that's just beautifully pristine, and if you ever get a chance to go, please do. It consists of 16 little villages that are all nestled in the hills. Very few Americans go there, so nobody hates us yet. And people are great, the wines are great, and this is a good example. Grenache is the grape that's king in this region, and most of these wines are blends of Grenache and Syrah. Sometimes another wine or two is thrown in there as well. But those are the two that are usually used. This particular wine, okay, is, as you see here, Cote de Rhone, just a label, simple Cote de Rhone. It's 60% Grenache, 40% Syrah. These are just very approachable, fresh, wonderful wines. This particular one has a great nose of this dark, kind of dark cherry, dark fruit. And then the flavors of plum and just dark, beautiful berry fruit comes through. Has a really nice acid level, so you get this freshness that also makes it very food friendly. And the finish on it is this really cool peppery wine. Karen, my wonderful other half, loves peppery wine, so this is one of her favorites. This is a great wine. This is also a wine that is very inexpensive. This particular bottle goes for around $10 or $11. And this was actually a very popular wine back when I was the event planner for our store. And we would have all these weddings that would want to buy 8 cases of wine and didn't want to spend a lot of money and wanted a wine that everybody would like, that would go with everything they served. It wasn't too hard to do, but it was a challenge. This is a great wine for that. Great with just dark meat, light meat, chicken, nothing. Great porch pounder on your back porch on a sunny day. So I invite you to have a glass and enjoy, and have a good evening.
Cheers, everyone. Thank you so much, Dr. Downs. Next, I'm going to introduce Dr. Michael Kershen. Dr. Kershen is the Chair of Operations for Colorado Imaging Associates. He completed his radiology residency at Baylor University Medical Center in Dallas, Texas, and his musculoskeletal radiology fellowship at the University of Virginia. Please welcome Dr. Michael Kershen.
Yeah, hi. Thanks for having me again. And we'll be talking about imaging of low back pain in general, but disc herniations in particular tonight. And so we'll just get started here. So imaging modalities we commonly use for looking at for working up low back pain is, of course, the X-ray, kind of the workhorse of what we use, particularly in trauma and acute low back pain, CT and MRI, ultrasound, and occasionally nuclear medicine that we'll get into the specific indications for each of those coming up. So X-ray, as I basically say in all of these talks, should be almost always the initial diagnostic imaging for all indications of almost anything, but low back pain in particular. It's less specific and sensitive than other modalities, but it can occasionally be invaluable and actually be needed to make a diagnosis, or it can be the diagnosis maker at the outset. Can be tailored to specific pathology. It's quick, easy, and cheap. It, of course, does carry a small radiation dosage, which is potentially deleterious to the patient. Standard X-ray for low back pain would be looking at a 3-view, which would be an AP, a lateral, and a cone down L5S1. We can do other special types of imaging to look for pars defects, as you can see the middle, the third slide here. We have oblique images that look at the pars interarticularis here. They call that the Scotty dog. And then we can do, for example, whole spine imaging that can look at the curvature of the spine for scoliosis. We can also do these as dynamic imaging, for example, flexion and extension to look at underlying instability of listhesis. CT, generally ordered in the setting of trauma, useful for acute onset of low back pain, especially in patients who are getting worked up either through the ER or cannot receive an MRI. It's about our best modality to look at hardware. It's a good modality to look at bony metastasis, and can be used in adjunct with myelography to look at disc herniations in patients not candidates for MRI. It's less sensitive for soft tissues, particularly herniated discs, but it's more sensitive for the evaluation of marrow in some cases. It's relatively quick, it's easy, it's more expensive, and it does carry, of course, a larger radiation dosage than most of the other modalities we'll be talking about. So here we just have a couple images of CTs. You can look on the second slide and see an acute compression fracture, probably in the setting of trauma. Here we'd have a myelogram that defines the nerve roots here, and you could look for subtle disc herniation or stenoses. And then looking on the far right here, we have a pretty clear case of extensive osteosclerotic metastatic disease. So MRI is kind of the most sensitive and, I would say, useful, quote unquote, useful modality for evaluation of low back pain, particularly of the more chronic etiology. Useful particularly for evaluation of disc pathology. Disc herniations are best seen on MRI in almost all cases. It's more sensitive for bone marrow edema, which can define chronicity of bone injury. And it's better, it's the best modality that we can look at, or we use for the evaluation of underlying stenoses, soft tissue injury like ligament injury, and underlying inflammatory conditions. There are less specific bony findings, so we may need a CT or an X-ray as adjunct. It's relatively slow. Scan times can be anywhere from 20 minutes and up. It's harder on certain patients, particularly those with claustrophobia, and it's also hard with patients with low back pain, right, to lay on their back and still for that long of a period of time. Very susceptible to metal artifact and motion, and certain patients may not qualify. For example, some with certain types of pacemakers or metal in the orbits, for example. Less optimal for hardware evaluation. Probably the big benefit is it does not carry a radiation dosage. Here we just have some examples of pathology here. We have a relatively normal T2 spine. And then here, if we look at the L4, L5 level, you see a big disc on the second slide here, herniated inferiorly, that's causing spinal stenosis and caudate equina nerve compression. It's also really helpful to look at other less common pathologies like discitis osteomyelitis here, which is well defined with bone marrow edema and paraspinal phlegmon. And then here we have a metastatic disease case, probably similar looking on CT to the one we saw a few slides ago. This one also may be one where we would need a CT to better define exactly what's going on with the bone marrow. Ultrasound, very rare. I would say that there are some indications for it in the low back, particularly palpable masses or evaluation of fluid collections. You get lipomas down there. You can get sebaceous cyst around there. Mainly it's to target very specific indications, not really used so much in this context of low back pain, but it can help define certain pathology, and can be used to target intervention. For example, if you have a postoperative fluid collection that you're worried might be infected, we can look at that to see if there's anything that may be amenable to aspiration. It's less expensive. There's no radiation. You get real-time feedback. It is operator dependent, and we can't image through bone or air, which is an issue if we're obviously trying to look around the spine. So here would just be an example on the left hand here of a well-defined hypoechoic mass that would be compatible with a lipoma. And then here we can see a complex fluid collection that in the appropriate clinical setting would be specific or suggestive of an abscess. We can use Doppler to assess blood flow, and Sydney images give real-time feedback and dynamic information. But nuclear medicine or bone scan, this is again a more rare indication. We often use this for specific indications like looking at metastatic disease. More rarely in this day and age, looking at infection. Can be used in some settings to localize a source of pain or to evaluate for potential underlying hardware loosening. It's definitely more expensive. It carries a high radiation dose. There's a long prep and scan time, and the imaging findings are often highly nonspecific. So we often need a CT or MRI to define exactly what's going on. There's false negatives and low resolution imaging. So here we can just see a million innumerable, probably blastic metastases throughout the axial and appendicular skeleton. On the middle here, if you're looking for a source of back pain, you see this uptake along the L2, L3 disc space with some erosions. Again, nonspecific. This could be discogenic with Schmorl's nodes and cause a source of pain. At that point, you'd probably want to rule out discitis osteomyelitis as well. And then you have a gallium scan here that can help define sites of infection. That's pretty rarely used anymore in the setting of low back pain. And that's all I got. So thank you for your time, and I'll answer any questions if anybody has any.
Thank you so much, Dr. Kershen. We're actually going to hold questions until the end, but please keep your questions ready. That being said, we are now moving on to our main presentation. I'm very, very happy to introduce Dr. Jacob Rumley. Dr. Rumley joined CSO in 2020 after completing an AO Spine Fellowship at Augusta University Medical Center in Augusta, Georgia. He now leads the AO Spine Fellowship at the Center for Spine and Orthopedics. As a proud Army veteran and medical director here at the Center for Spine and Orthopedics, Dr. Rumley also loves serving the communities that he grew up in here. So here is Dr. Rumley for our main presentation on disc herniations. When do they matter? Take it away.
Okay, hold on. I'm pulling up my stuff. Yeah, tell me if it's working. Oh, there we go. Take my subtitles off. Okay.
You're good. You're working.
Perfect. All right, guys. Glad to be on again. I feel like Spine and Wine is just kind of something I plan on doing once or twice a year. So I think in the past we talked about back pain, and one of the more common questions I got actually was related to lumbar disc herniations. And I think one of the most common things that get sent is consults are disc herniations in people with back pain, and trying to figure out, if this is surgical or not. So I thought I'd give everybody kind of a glimpse into that. So quick overview and our learning objectives, which are required for a CME event. And I think these are the most important parts of this, are one, to describe the red flags of lumbar disc herniations, not just back pain. Number two is to explain the natural history of lumbar disc herniations, and last, describe treatment algorithms. And I would say that that's really also going to lean on the pain management, chiropractics, and physical therapy sides. So first of all, to talk about disc herniations when they matter, you got to know what they are. So the disc is really talking about two layers: the annulus fibrosus, which is that thick blue layer, then the nucleus pulposus, which is a remnant of the notochord from our developmental anatomy. And these are actually incredibly strong just on their own. A healthy disc can withstand over 2,000 newtons of force. That's the equivalent of having like 449, I'm doing the math in my head, 449 kilogram or no pounds, like puts directly on your head. So that's a lot of force, and that's a compressive force. So it's actually in all directions. So a lot of times also people forget that this is an avascular structure. There are no vascular infiltration into the disc after the age of 18. So that goes into some things later that Dr. Leo and whatnot can talk about, but that's why, the regeneration of discs just have gone poorly, because if it went well, I'd be the first one to be doing it. Now, disc herniations, we got to describe what we see and what is a disc herniation. Now, there's a lot of different classification systems. Right here, I have the AO classification system, and I personally like this one the most. It's mostly because they kind of describe what surgeons think about. So we have in the top a bulge, is kind of like a broad-based degeneration or breakdown of the annulus, and usually the width of it is much wider than it is deep. You get to protrusions. This is where the jelly starts pushing out into the annulus fibrosus, and actually you have a break in that annulus at that point. But if that remains contained and the annulus is completely broken, that's when we call it an extrusion. Now, these can be contained, which I see a fair amount of these chronically. People who've had a previous quote unquote disc herniation a while ago that's gotten better. Maybe they've done a lot of physical therapy. They come back and it typically looks like a contained extrusion. A lot of the patients who have extreme radiculopathy will present with a uncontained extrusion. That's where this whole thing is just pushed out. And there's a lot of inflammatory mediators on this or in the nucleus pulposus, and that causes a lot of pain. Lastly, we get a sequestration where it'll usually go either up or down, cephalad or caudal, along the spine. Then lastly, there's a thing called a pseudo herniation, which we hear about a lot. And actually, you'll see these also called bulges. Okay, a pseudo herniation is just where the spine has moved. It's usually associated with a spondylolisthesis going forward. And in doing so, we get a doubling of the disc in the back. It stretches out in the front, it's kind of loose in the back. And the disc is actually relatively healthy, and it's not a problem of the disc. It's just now we're seeing what appears to be a push out or a bump, or frequently called a bulge. Oh gosh. Okay. There's other ways that we describe them, and most importantly, I'm going to talk about some locations on the next slide. So understanding why these locations matter also depends on where it's at. So we're going to create some baseline terminology. Number one is we have grades. Okay, grades are where does the back of that herniation go to? So a grade 1, it's the anterior aspect of the facet. Now that's on a healthy facet. So some people's facets almost touch the vertebral body. We kind of try to decide what a healthy facet would be, but a lot of times we'll get reports where it talks about an unhealthy facet. So they'll actually say it's a grade 2, which means it goes to the posterior aspect of that inferior caudal lamina. Then at grade 3 means it goes beyond that. But strangely, how far that disc goes backwards has no correlation with how severe their disease is, which makes our jobs even harder. Now, the zone, which is on the right, is very important. So we have central, which means that they are with medial to the facets, okay, the medial border of the facet. You have lateral recess, which is underneath the articular portion. We will frequently say the medial edge of the dura, which is hard to see in somebody who's got a pretty displaced disc. Then lateral to the pedicle. Then far lateral or foraminal, we call it the pedicle border lateral. Now, I will frequently say foraminal, meaning medial to lateral border of the pedicle, and far lateral to that, but a fair amount of time, the concept of far lateral and lateral are about the same. So this is why the location matters. If this is a L4 in the top and L5 at the bottom of that disc space that has a herniation, you can see right there, where that herniation presents or where it goes determines which nerve is affected. And I mean, this is probably the most common thing that we see people struggle with, even spine surgeons. Sometimes, they'll be thinking about a 4 or 5 disc herniation, but it affects the L4. So they assume it has to be a far lateral or a foraminal disc herniation, but you can get an extrusion with cephalad migration that will go up and hit the L4 nerve root. So far lateral, foraminal, cephalad will go up. A paracentral, meaning it's in that lateral recess, usually gets the nerve root going down. That'd be L5 or inferior migration. Now, lastly, central herniations, they can hit anything. They will typically hit the lateral recess, though. Even if they're very central, for some reason, that chemical neuritis tends to affect the nerve root that's traversing. So when we ask, like, okay, what's a disc herniation look like in a person, not on imaging? These are typically patients with sciatica and radiculopathy. That means they have pain, burning, tingling, and numbness. It is typically down one leg. I mean, I would say that's the average because they tend to be paracentral. So I think it makes sense. But a lot of the times patients will have a very specific, like, it is an electric shock down my leg. It's very sharp. The burning tends to be at rest, and that's as it's kind of like when you sit for too long and your leg starts to burn when you're watching a movie and you stand up and get the blood back into it. That's usually what I think people talk about with burning. But also you have to remember it tends to be positional. So standing, walking, it tends to be worse. Sitting, usually doesn't make it worse, but some people will get worse with sitting, and it has more to do with leg position. As they flex their hips, that puts the nerve root on tension. Most of these patients will come in with their back extended and their leg flexed, and they'll keep their knee bent because they don't want to straighten it. We'll talk about that sign in a second. And almost always they have low back pain, and they present with almost spasm-like symptoms. So the red flags right here are not for disc herniations. These are for back pain. There may have been a talk by a real eloquent spine surgeon recently on this topic, but the red flag symptoms I'm really worried about have to do with a disc herniation red flag symptoms. Those are usually going to be, I think most people know what cauda equina is. So they have numbness in the groin, bowel loss, which is diarrhea. Usually they don't get, they won't like urinate just randomly. Usually it's an overflow urination, because what happens is those detrusor muscles lose the ability to flex down and urinate. But it's usually not a problem of the inability to hold it back. That's usually a parasympathetic, sympathetic activity. But they will pee once their detrusors become too full that it just stretches and they get an overflow urination. They'll also usually have a fair amount of urine in their bladder after they pee. That's where a bladder scan can be helpful. I know we talked about ultrasound a little bit ago. As a spine surgeon, that's the most common time I'll use that to help. If they have weakness that's worse than 3 out of 5 on the musculoskeletal grading scale, that concerns me. And for an insurance company, that will usually trigger an immediate MRI. They should still get an X-ray first, however. And additionally, that does not prevent them from getting physical therapy treatment. I treat a lot of patients with complete foot drop, but it usually triggers a earlier MRI workup. Lastly, if they have fever with radiculopathy and a disc herniation, that immediately gets treated, and it needs to be ruled out for a discitis or a epidural abscess. We know that with epidural abscesses, about 12% of those will have skip abscesses. So if we see an abscess, we get the entire spine imaged, and usually in the emergency room. Shouldn't be doing that from clinic. So how do we herniate? So this is going to be a lot of things that cause it. So number one, when we stand up, we have gravitational forces on our spine. That doesn't cause a disc herniation. Then we have external forces, which I'll show you in a second. That can cause a herniation. But when we do physical activities, we have significant muscle tensions that typically can lead to a herniation. What's interesting is there's a couple of papers that show the most common reasons for people to herniate discs are sneezing, coughing, bending over to tie shoes, and lifting small amounts of weight. In a lot of work comp questions, they'll say the weight was not greater than 70 pounds. And I always, as a spine surgeon, kind of laugh because most people don't have 70-pound shoelaces, yet they herniate with that. So this is something called load amplification. Everybody's heard lift with your legs, not with your back. Well, Betty White right here is getting ready to show us how not to do it. Now, there's going to be some complex arrows in math. So the weight of the body, 2/3 of the body above the waist, is 500 newtons. Okay, that's her weight going straight down across the low back that she's bending over. Okay, we have the second weight, which is this box she's carrying. That's 10 newtons. Okay, and that's pulling down. And she has muscle tensions because when she bends over, her spine doesn't want to fall off. So those muscles start firing. That pulls straight down and loads the spine. But that also reinforces the spine and gives us a little strength, but generally creates some downward force. Okay, now we're going to go into crazy math that nobody needs to know. These are for my spine fellow to try to explain, and he has trouble with it, so we won't hold him against that. But basically know that the next one right there is bending over and holding a 10 Newton box, which is 40 pounds, is 1,300 Newtons of force on the spine. That is an insane amount of force. So that's why it really doesn't take a lot for you to herniate a disc. And that's why we say bend with your knees, is because bending forward, carrying that secondary weight creates a huge amount of force. So when we talk about spinal forces, here's a couple of passive forces just doing normal things. This is how much force the spine just sees. So the passive strength of the cervical spine, or the ability of your cervical spine in a cadaver with no bones, nothing working on it, it can withstand 10 newtons of force before you either get a dislocation or a tear. The thoracic spine before fracture is 20 newtons, right? And, that's not a lot of weight. That's like, I think 30 pounds. The lumbar spine can withstand 88 newtons. That's without the muscles. Then when you start adding preloads, which is the muscles creating force just by doing things, when we lay supine in bed, our spine experiences 200 newtons of force. Now remember, the native spine with the muscle activation should be able to withstand 2,000 newtons. So that's why laying supine isn't a ton of force. Recumbent, okay, laying on your stomach is 300 newtons. Then if you stand with your body flexed, not holding any weight, 30 degrees, and you weigh more than Betty White, that's 400 newtons of force. That's a lot of force just doing normal things. That's why people will herniate discs sneezing, is because they have such a fast forward flexion that their muscles aren't able to contract quick enough. So what are the physical exam findings when we sneeze or tie our shoelaces and herniate a disc? Well, number one, people have guarding. They don't want you to, let me go back one. They don't want you to bend their leg. They don't want to bend their leg, and they sit in that extended knee flex position. They will usually also have a painful scoliosis where they bend their body away from the herniation. A lot of times they'll have sensory changes, and that doesn't mean their entire foot is numb. It's usually dermatomal, the top of the foot, the bottom of the foot, the side of the foot. Usually they'll also have isolated weakness, which we'll go over some of those myotomes in a minute, but just know that the textbooks are frequently not 100% right. We know about 10% of people do not follow the established dermatomal distributions, especially when it comes to foot drop, the ability to dorsiflex the ankle and extend the knee. It has a lot of crossover between 3 or 4 or 5 and 3 4 respectively. They will frequently have a diminished reflex, so you get reflex on one side, you don't get one on the other. However, if they have diminished reflexes bilaterally, that's normal. Lastly, they'll usually have nerve root tension signs, which I'll show you in a minute. So here's an explanation of a painful scoliosis, right? So when the guy on the left has a herniated disc, he's bending away to create room for that nerve root to get by. If he bends to that side, it can actually sublux it on the traversing nerve root and cause a significant amount of pain. So that's why you won't see patients fake it. That's also one of the things that I try to observe as I move around the room, is to see if the patient moves their body, because that can be a good sign if it's a painful scoliosis or if it's a symptom magnification. So here's from Hoppenfeld's, the classic motor distributions and sensory distributions of the 3 most common nerves affected, L4, 5, and S1. So we test motor with tibialis anterior or ankle dorsiflexion. We also do the patellar reflex for L4. Interestingly, the motor to the knee tends to be L3 extension. It's just accept it, just memorize it. It's fine. That's far beyond the needs of this talk. Sensation is the medial toe, then up the anterior leg. If it crosses the knee, it's rarely L3 is a little thing to remember. It's a little rhyme. I'm an orthopedic spine surgeon, so I need easy things like that. The extensor hallucis longus, or the big toe, is the best for determining L5 weakness. However, some people with an isolated L5 will have a complete drop foot, so the tibialis anterior doesn't fire. Just understand that that is a common variant that we'll see. So you don't have to be worried about a 2-level disc herniation, and they're not malingering. It just means that they have more of a L5 dominated tibialis anterior. The distribution of L5 is typically the dorsum of the foot. Sometimes people will have some medial or lateral foot crossover. It is common, but typically L5 dermatomal distribution is pretty straightforward. Then lastly, for sensation, at S1 tends to be the lateral and posterior foot. You test that with a gastroc, so toe raises. Now, if a patient sits and plantar flexes, the likelihood of you being able to pick up any subtle weakness is very low. I will frequently have them plantar flex and externally or abduct the foot. What that does is it tends to be less gastroc more peroneus brevis. The Achilles tendon reflex is the most common, and if they get multiple beats of that reflex, that's called clonus. Up to 3 beats of clonus is normal. With a Achilles reflex, I find a lot of medical students and other doctors having trouble getting it. So typically what I do is I will test for 1 beat of clonus, and if I get 1 beat of clonus, I don't even bother with their Achilles reflex because frequently it will not be present because they've already enacted that reflex arc. So just understand there is a fair amount of crossover between these. So this is an example of the straight leg raise. So in the straight leg raise or a Lessig sign, we typically have the patient lie down, lift their foot, and they should get this pain all the way down to the foot. If it stops in the hamstring, that could be tight hamstrings, piriformis syndrome of sciatica. Could be a disc herniation still, but a classic straight leg raise goes all the way to the foot. A contralateral straight leg raise, if you do the other foot and they get pain on the contralateral side. So if they have a left-sided disc and you do a straight leg raise on the right and they get left-sided pain, that's actually very, very positively predicting that they will have a radiculopathy on that contralateral side. And you can add an ankle dorsiflexion to increase the nerve tension to really make this more sensitive. I will typically do this with the patient seated and distracted, which is common to look for symptom magnification. By having the patient seated, if I can straighten their leg when I'm doing L3 strength testing with knee extension and they don't get any pain down to their foot, I document that, especially if then they have a positive straight leg raise. That's concerning. Femoral stretch test is better for L3 and sometimes L4 disc herniations where you're actually lengthening the femoral nerve. This can also be associated if patients have tight hip flexors. This can also be painful. So it should be recreating the radicular symptoms going down to the knee. If it crosses to the knee, to the dorsum of the foot, that's anatomically not common, but it could be their saphenous nerve, which goes down to the medial ankle, is also picking up the pain. So I'll talk in a minute about a lot of the initial treatment options with these guys. So we have Dr. Leo on the left. He's going to be up next. Then we have our physical therapy and chiropractic partners. Just know that they're smarter than me, and there's going to be a little bit of overlapping. So to reinforce the imaging side, ideally, we use imaging to confirm our diagnosis. However, I'm surprised all the time. I don't always think that I know the diagnosis before it happens. I will frequently, if they have these disc herniation signs, I get them to physical therapy or chiropractics. Then if they fail that, unless they have red flag symptoms, then we'll get MRI. I get a radiograph on initial presentation. That is against the guidelines by the American Academy of Family Practice. But I'm a spine surgeon, and I think there's some medical legal reasons why we get the initial x-ray that are beyond the stock. The positive findings that we see in a patient who's asymptomatic on an MRI are very concerning. So just know that 30% of patients who have no symptoms will have significant abnormalities on MRI. That's why I send them to physical therapy first, is because if they don't do the physical therapy, which you're going to make them do just for pain without red flag symptoms, you may be finding something that's not the problem. I would say the classic example for me is piriformis syndrome. Then once again, after 6 weeks of physical therapy and chiropractics then I'll send them for the MRI unless they have those red flag symptoms for disc herniation. So my initial conservative treatments are, if medically acceptable, so I'm not going to give NSAIDs to patients with bad GI bleed risk or renal disease. NSAIDs right away. I usually tell them to modify their activities. Again, physical therapy and chiropractic should be the standard. Steroids and neuroleptics, gabapentin, are frequently given I do not give steroids, but I frequently will give gabapentin. Sometimes I'll even send them if they're really in excruciating pain for a selective nerve root block after an MRI. Don't do it beforehand. And typically 90% of these patients will get good improvement from conservative treatment. So only 10% of these patients require surgery. So that's why conservative treatment is hammered by insurance companies so much. So a couple of important papers. First of all, the Weber paper is a 10-year observational study where they had about 130 patients who had lumbar disc herniations who were randomized between surgical and conservative treatments. In 1 year, the surgical group had less pain, but after 4 years, there's no difference. Um, there are some appropriate concerns with the paper. A lot of this has to do with any paper published in 1983 had a lot of surgeon bias. Um, but in the end, they didn't really take into account strength and things like that. It was just disc herniations with radiculopathy. So there's some nuance to this, but just know that's something you can tell your patients. Like, listen, most patients that don't get surgery are going to do well. And this was actually proven in the sport trial. There's sport 1 and 2. They were published 4 years apart, but these are big papers. So frequently spine surgeons will rag on these papers, but if you read them the way they should be, which is that if you allow patients to decide what they need, surgery or no surgery after completing non-operative treatments, they usually choose the right treatment. So at 3 months, the patients who had surgery, who chose to have surgery, had better outcomes than those who didn't. However, at 2 years, the differences were almost nothing. At 4 years, there was no difference at all between the surgical and non-surgical groups, with the understanding that the patients chose which treatment they wanted. A couple of things, oral steroids. I find myself having these discussions with pain management all the time, and I like to try to prove them wrong in public opinion in public. So first of all, oral steroids for acute radiculopathy due to a herniated disc trial from JAMA 2015 showed a short course of oral steroids when compared to placebo had a modest improvement in function and no significant improvement in pain. So you give patients steroids compared to nothing at all, they have a little bit better improvement in function, but their pain is actually not that much better. What they do notice is they're like, I was wired, I didn't sleep, my shoulder pain, my knee pain, all that was gone. But really, when you drill down into it, their pain is not significantly better. I know that a lot of providers will say, well, I know in my patients, they all say they feel better. I think they do all say they feel a lot better, but that's why I recommend nonsteroidal anti-inflammatories initially. Additionally, the gastric risks and whatnot with these and patients with diabetes, when we give them oral steroids, which I'll actually see a fair amount, can throw their sugars out of control. And sometimes they're not a operative candidate because we're having trouble with sugar control just from a single Medrol dose pack. So keep that in mind. A young, healthy person, yeah, it's probably okay, but I don't know if the literature really strongly supports it. Then the other paper that I would say about gabapentin, they compared Lyrica versus placebo. And this is a paper from it's Cirrus, which is not a big publication, but it's a really good paper. And they showed that giving Lyrica in the addition of an NSAID and physical therapy, most important physical therapy, did not really reduce their pain reduction. However, I give almost everybody who comes in with radiculopathy gabapentin or Lyrica. I will say that when compared to narcotics and other things, it's a lot safer. So real quick, surgical options. I'm going to blast through this because our goal is to not do surgery on these patients. Number one is understand that there's open, which is small incision where we move the muscle to the side, versus minimally invasive with a tubular retractor where you just put it right through the muscle. 2 ways to get at the disc with no difference in any papers. There are some small differences early on, but more of the long-term stuff, in my opinion, in my review of the papers, there's really no big difference. And actually the incision sizes are actually of minimal difference. Some other surgical treatments that people can end up with from just disc herniations come from patients who have a disc herniation that breaks down over time or they have significant instability. That can lead to, right here is an anterior based fusion in the middle one, or on the right is a lumbar disc arthroplasty where it's allowed to move. Both can be good options if required. Okay. But we don't talk to patients about this early on. Decompression is the goal. A very good paper from the Asian Spine Journal. Once again, not a monster journal. It's actually pretty well read, but certainly not JAMA. Looked at patients who had motor recovery after micro disc treatment. So I'm going to throw this out there because I'm a strong believer in this paper, what it showed you. So what their goals were to determine how much strength improvement do we get from doing a decompression of the nerve if they had weakness. It did not include patients with cauda equina. Those all get surgery. So historically, they say that 60 to 80, 90% of patients will have significant motor recovery. But once again, we don't really talk about what is motor recovery. There is no consensus on what factors are associated with recovery of a nerve. So how long do they have symptoms? Hasn't really been shown. If they're younger or older, they maybe have better improvement according to one paper. There's more than 25% of the canal compromised. We used to say, well, those patients, if you do a decompression, are more likely to do better than if you watch them. But nothing, that should say nothing, not noting, nothing has been shown in most of the papers to be predictive. So in this one, they took 70 patients with a disc herniation who had motor deficits of 3 out of 5 or worse, and they could not have cauda equina again. And if they had tandem stenosis or isolated sensory deficits, they didn't include them. Tandem stenosis would mean that they have also a neck problem. So they looked at them postoperatively, then they looked at them, preoperatively, then postoperatively up to 3 months afterwards. Then they looked at them again at a year. If they had symptoms, they tried to track how long they had symptoms for. So if it was acute, they had symptoms for less than 3 months, chronic more than 3 months, or if they had chronic symptoms but had acute worsening, that was then considered acute on chronic. And they tried to look at the number of total previous episodes. So the neurologic assessment that they kept track of were how many herniated discs were there? What was the index level or the first level of herniation? And what kind of herniation was it, which we already talked about? And did it migrate? Lastly, on the axial cuts, they looked at the herniation size and the percentage of the canal compromise. And lastly, they looked at the bony canal dimensions because of the amount of bone then determines do they have congenital stenosis? Are they naturally smaller? They then performed a surgical procedure on these patients. So they did a microdiscectomy under anesthesia, which they opened up the bone and removed the disc and sometimes would create a larger hole. That was up to surgeon determination of need. Then they considered a significant motor recovery as having motor power of at least grade 4. Now, real quick, I'm going to throw in my bias. Grade 4 motor recovery is the most ridiculous way of determining it because if I can bench press a 90-pound dumbbell on my right side and a 5 on my left, that's 4 out of 5 motor recovery. If I can bench press a 90-pound dumbbell and an 89 on my left side, that is a 4 out of 5 recovery. They're just showing it's more than a 3 out of 5 after the decompression. So of the 70 patients, most actually came back, which is very uncommon for spine research. The complete recovery, so patients who got 5 out of 5 strength back at 2 months, 63%. Greater than 6 months, 6.1%. No recovery after 12 months was 20 patients or 30%. So that's pretty wild, right? Like, so if you add those up, you have a third of the patients who didn't get any improvement. So when they looked at like the risk factors or why they got it, so if a patient was diabetic, that was an independent risk factor of them not having a recovery. But smoking wasn't, their work wasn't, male or female wasn't, their age wasn't. Also, if they had multiple comorbidities, if they were generally sicker, that was a negative predictive factor. So they did do a side report on patients with bladder deficits. 47% had early motor recovery of their cauda equina. And there's no association between decreased anal tone and motor bladder recovery. So if they came in with nothing, they could still get it back. On radiologic assessment, they looked at the patients. If they had a single disc herniation, they were more likely to have motor recovery than it was multi-level herniations. So if they have one big, juicy, acute disc with weakness, those actually are more likely to come back in their cohort. They do need to do a significant further assessment of this because it is a good paper that makes us think, and we're trying to repeat it at our program. So I would say the biggest predictors of recovery that they identified is if a patient's not diabetic, short duration, less than 2 episodes of herniations, incomplete motor and sensory loss, and reflexes are present with less than 2 levels of herniation, more likely to have a good outcome. Limitations we already talked about. Then lastly, I would say that no matter what, if a patient has significant motor loss, we should get them back. Okay, my final thoughts is recurrent disc herniations typically follow the same guidelines as I just said. That, you know, and according to that, if they had less than 2 recurrences, they were more likely to have recovery. We need to watch out for the red flags. And most of the patients will get better without surgery, but if they have a significant motor deficit, we should probably pay attention and get them into a spine surgeon right away. Then lastly, never hesitate to give me a call if you have a question, because that's a heck of a lot easier than trying to work through the referral guideline or referral pipelines that we all work with. So for all the providers, Jenna will be giving you guys my cell phone number. So off to a message from my colleagues. I got a picture of Dr. Leo there for you. I'll introduce Dr. Leo. I'm going to go off share real quick if I can. Stop share. Okay, so Dr. Leo is next. He's going to present on the pain management side. Dr. Leo is a board certified anesthesiologist and pain medicine specialist and a good friend of mine. He specializes in interventional pain management, spine injections, radiofrequency ablation, and cryotherapy ablations. He's also a huge Mets fan, and so he's actually been in a good mood recently. So that's been kind of nice. So if everybody would welcome Dr. Leo.
All right, how are we doing here? We're on.
Dr. Leo's sitting here watching the Mets, so here we go.
I knew it. I knew he. I mean, as soon as the Mets were in the playoffs, I was wondering if I was going to have to give this talk.
Yes, Dr. Leo's mad at me for scheduling this during the Mets playoffs game, so my apologies. But here we go.
We're up.
Can everyone see Dr. Leo's slides?
Advance these puppies.
Can everyone see the slides?
So for anyone who matters and minds LFGM, can they hear me? Are we on audio? We're good. All right. So thank you, Dr. Rumley, for the kind introduction. And right now it's 2-0 Dodgers, but the Mets have the bases loaded.
Hey, Jenna, I can't see the slides real quick.
All right. They cannot see slides. So
Sorry, that would be why no one confirmed. Hold on.
we're trying again.
How are we doing now, everybody?
Great.
Yeah?
All right. So do you need to put it up to the slideshow?
All right. Oops.
We still good?
All right.
All righty, let's try that again. Anyway, Dr. Rumley, thank you very much. Yes, the Met game is on. Currently, the Dodgers are winning, but we got the bases loaded. Okay, we need this for to win, so I get to use this tonight. Thank you. So to talk about the pain management side of this in 5 minutes, it's going to be a bit like drinking from a fire hose. So let me just emphasize first that a good physical exam is necessary for anything we do here right now. And you may have things that show up on an MRI or show up on an X-ray, but it is the physical exam and the patient's findings and history that are going to lead us to the right answer. So a radiculopathic pain is typically pain, numbness, tingling, or weakness in the dermatomal or myotomal pattern, which we've already heard about. There are some lookalikes that go with that. So you can have what we call a double squeeze. So you can have compression of a nerve root in the neck, but you can also have a carpal tunnel or cubital tunnel syndrome, and they both look alike and cover the same area. So it could be one or the other or both. Similarly, in the low back with the lumbar plexus or the tarsal tunnel. Another look-alike is the sacroiliac joint, which has been called the great mimicker. So that can look like back pain, pain into the buttock, the low leg, and down as far as the ankle. And that is often the determiner for me, is if it's pain to their ankle, it actually may be their SI joint. It may not be coming from their spine. So brief return to medical school, or whichever school you went to where we learned about this stuff. The dermatomes are fairly well marked out in any chart that you're going to get. Not everybody's body follows those pictures. Not everyone has a netter body. So you have to use a little bit of your physical exam to go with that. So including reflexes, sensory, muscle strengths, and weaknesses as we look for signs of nerve root impingement. The epidural space runs from the foramen magnum, so right up here, really all the way down to the sacral hiatus. And you've got 7 cervical vertebrae, 12 thoracic, 5 lumbar, and the sacrum and coccyx. So what's going on when we're going to do injections? This is a cross-sectional view, the disc, and we've already seen the radiology for this. The disc is going to be anterior. You have the space formed and the tube that's formed by the stack of vertebrae. And that holds in the lumbar region the epidural space, the dura, the CSF, and the nerve roots of the cauda equina, which hang down and get distributed as we move further caudally. And those can be impinged upon by a variety of places, which have also been discussed. Something I'd like you to think about in the cervical spine is that when we are placing needles here, instead of a sac full of fluid and a couple of nerve roots, we've got a spinal cord that can be a few millimeters away from where we're trying to put the medication in the needle. So this is a place where here be dragons. So we want to be sure with imaging and with a good physical exam that we are going to the right place when we ask to do one of these. So that's just a brief review of the anatomy. In terms of medications, we've already spoken about more conservative care, physical therapy, chiropractic, osteopathic manipulation, anything we can do, Rolfing, massage therapy to try to loosen this up and work it before we do injections. The medications were discussed fairly well by Dr. Rumley as well. So when I do an injection of local anesthetic, whether I use an approach interlaminar from the midline or transforaminal from the side targeting a particular nerve root, is typically going to be a mixture of a local anesthetic, usually bupivacaine, ropivacaine, or lidocaine, which are chosen primarily for their duration of action, and a steroid, unless it is a purely diagnostic block. And that should be particulate and preservative free. We do not want to put any preservatives in the epidural space because we do not want to preserve the nerves. And it should be particulate free because the things that did not show up on any of these pictures is the vascular supply. And if you inadvertently put a needle into an artery and inject a particulate steroid, you will embolize and kill either some nerves, or you will embolize the spinal cord, and that is lethal in the cervical region. So always particulate and preservative free for what you're injecting. Some more novel items now are a sweet epidural, which is using D5 instead of a steroid. And there is now an injectable product, which is cadaver disc, which can be injected into the disc and has been FDA approved and has worked for a cohort of people to improve their disc space and their pain and avoid surgery. So the times to use this is in a setting of pain when we have done physical exam, when they've, quote, failed physical therapy, which is not a failure. Often, if their pain is controlled by one of the injections described, they don't have a problem going back to therapy and doing stuff at home because it doesn't hurt as much. But having a good idea of where we go and where a good target is the key to making one of these work. So it's patient selection and physical therapy. So that is a very brief look at what an epidural steroid injection can offer, and sort of where we have to go and what we have to do. These are guided by usually X-ray. Some can be guided with ultrasound now, and all of ours are done under one of those conditions. So thank you very much for your attention, and I will be happy to answer any questions at the end of the talk. Thank you very much.
Thank you so much, Dr. Leo, and hopefully your Mets can rally here for you, as much as that pains me to say as a Braves fan. But go Mets. Anyway, thank you so much, Dr. Leo. Our next presentation is on the chiropractic side of disc herniations. If you guys weren't familiar already, we're very pleased to have introduced chiropractic care at CSO this year with the addition of Dr. Benjamin Cowin to our staff. Dr. Cowin is a doctor of chiropractic, specializing in non-surgical sports medicine and chiropractic care. He brings over 20 years of experience in sports chiropractic, dry needling, neuromuscular skeletal rehabilitation, and more. He's also the go-to chiropractor for the most of the head referees in the state of Colorado, as well as the Big 10 and Big 12. So please welcome Dr. Cowin.
Thank you, Jenna, and thank you for having me on. Really appreciate you guys taking the time out to join us on these talks, and already learning quite a bit. Thanks, Dr. Rumley and Dr. Leo, for your talks. Dr. Leo, I was keeping tabs on the game. Sorry about leaving the bases loaded in there for you. So, all right. So what I'm going to talk about today, and if I could leave you with one thing to take away, as we talk tonight, is there's a lot of different ways that we can treat. We've got a lot of bullets in the chamber for treating disc pathologies. And so on the chiropractic side of things, kind of the take home message is don't get addicted to the crack, right? Don't get addicted to that pop. And, oh, well, I need a pop for it to be successful. Oftentimes, especially in the way that I treat, while joint mobilization and manipulations are great, we've just got too many other therapies, other modalities that we can be using, and we don't necessarily need these high velocity type of activity. And so one of the big things that we want to talk about is the difference between structure and function, right? Just because we have some type of structural change, being that disc pathology, doesn't necessarily mean that we can't improve the overall function. And my background being sports, specifically professional sports and Olympics and things of that nature, oftentimes we would have athletes that have some type of structural issue that, hey, listen, we got to play. Like, there is no ifs, ands, or but about it. And in your patient population, it's no different, right? Just because we see something on an MRI or see something on an X-ray doesn't necessarily mean that we have to go down certain pathways as far as treatment strategies. That's great data, and the more data we have, the better educated decision we can make. But just because we see something on an MRI doesn't necessarily mean, oh, well, we have to get this fixed. And we see that quite often with the way that we treat and the patients that we see. And so a couple of the things that I like to look at as far as from the functional, the performance side of things, is what does the kinetic chain say? And really we get back to why is this disc overloaded? What has happened that all of a sudden this the disc and the lumbar spine has been taking too much load? And the big question, we've seen some great papers that have come out recently. What do the hips say? And oftentimes what we can see is if with lumbar spine issues, and not just disc, but just lumbar spine pain, or yes discs and some of the other things that we see, is that we can directly tie that back to some type of hip tightness, whether it's a problem with the internal external rotation or like Dr. Rumley said, piriformis syndrome and things like that. So can we look at the hips and see a decrease in range of motion in the hips and maybe start looking at things like the piriformis, looking at things like pectineus, which decreases as that goes into spasm, decreases that internal rotation of the femur, which when we're talking ambulatory gait directly influences what happens during swing phase. If we do see pectineus tight, oftentimes what we'll see is some type of compensatory change where we're using things like quadratus lumborum to hip hike rather than a stable pelvis, which will then allow us to swing through phase. So looking at the hips and being able to say, okay, well, can we increase range of motion at the hips? And by doing so, would that take some tension off the lumbar spine? If we can do that and take tension off that disc, would that in turn get us more functional? If that's the case, how do we treat? Well, if we can restore function to the patient, ultimately that's at least in my line, that's the goal. So yes, talking about manipulation is a great type of modality, but there are a lot of other considerations, a lot of other types of modalities that we can throw at a patient to increase that overall function. Whether it's dry needling, whether it's pin and stretch, also known as active release, different types of soft tissue techniques, different types of stretching techniques as well. We can look at the fascia as it relates to the other the structures surrounding using techniques like Graston technique or assisted soft tissue mobilization, cupping for different types of things as well. And so we have a lot of different options as we look at that. But I think back to what both doctors have already said, evaluation is key. Once we can get into that eval and look and say, okay, yes, you have low back pain, and while I acknowledge that and we can look at that, we have a lot of different options to see, is that what is limiting our function, or by increasing some of the structures surrounding increasing that mobility or whatever it might be, could we potentially increase function and therefore get them back to whatever makes them happy? So when we talk about mobilization or manipulation type of techniques, yes, from a chiropractic standpoint, we talk a lot about that grade 5, that high velocity, low amplitude type of a thrust. Important to note, though, that there are a lot of different ways to skin that cat, right? We can look at different types of stress strain methods, different types of activation methods like PIR or post-isometric relaxation technique. We're using the muscles to generate the force. That in turn will kind of reset some of that joint mobility and kind of realign some of that malformation of the joints. And I think over especially in the practice. So I was in practice for about 10 years before stepping away from private practice and taking some time off after the games. And then recently, about 3 months ago, I joined this practice. And I think the one thing that has impressed me most about being here at CSO and just the environment is the collaboration. And collaboration is key. And I can't tell you how many times I've been at the X-ray stand here and looking at an MRI or looking at an X-ray, and Dr. Rumley has to be standing there, or Dr. Leo or Dr. Leinbach, and kind of peek over my shoulder and look and go, hey, this is what I'm seeing. Have you considered this? And so back to the whole lot of bullets in the chamber, that collaborative effect that we have here, being able to have a lot of different opinions and a lot of different focus to look and go, hey, I think this is what's best for your patient. And maybe it's my skill set, maybe it's not. And the nice thing is that having all of us under one roof, being able to talk, and in fact, I had conversations with both Leo and Rumley today about, hey, having an issue with some things. What do you think? It's really nice to be able to kind of look at that spectrum of treatment, everything from surgery all the way to the ultra conservative from chiropractic and everything in between, and go, hey, this is what I think. This is how I can help. This is maybe we try this, and being able to collaborate and ultimately improve overall function. So, all right, thank you for your time. That's all I'm gonna spend on, and I will answer questions at the end.
Awesome. Thank you so much, Dr. Cohen. That was great. Next, we have Patrick Cook, PT, DPT, CSCS, and there are a few others on there that I can't list them all. So Thank you, Patrick, for having way too many credentials in a good way. So our next presentation is on the physical therapy side of disc herniation care. And similarly to us adding chiropractic care to our practice this year, we also added our own physical therapy clinic in December of 2023. So this is our first, full calendar year with a physical therapy clinic. It's been a really great resource for all of our physicians and patients, as hopefully you guys are learning. Patrick Cook is one of our really great physical therapists. He is also a strength and conditioning specialist. He's certified in applied functional science through the Gray Institute. He's also a level 2 dry needling specialist, and he's studying for his orthopedic specialist credentialing. So with that being said, please welcome Patrick Cook, and he's going to speak a little bit on the physical therapy perspective for disc herniation care.
Thank you, Jenna, for the awesome introduction. Okay, so let's see. Can everybody see that? Let me go to...
Yes, we can see it.
There it goes. If I do this. All right.
Yes, you're good to go.
Great. All right, so thank you all for being here. It really is amazing that I get to be here among some incredible physicians and healthcare professionals who truly care to deliver not just the low bar of do no harm, but the higher standard of doing the most possible good. So I hope that this presentation shows how PT fits into that same standard of care. So right off the bat, how do we troubleshoot disc herniations as physical therapists? Well, it all starts off with a very thorough history, which typically involves the symptomology of back pain, buttock and hip pain, radicular symptoms, or any combination thereof. We try to gain as much insight to the mechanics of their symptoms, including aggravating and alleviating factors, time of day, etc. Typically, disc problems worsen with prolonged upright activity due to the nature of gradual disc desiccation and loss of disc height, secondary to our body mass and gravity and time, which may or may not involve unilateral or bilateral radiculopathy. So part of that thorough history is reviewing the SINs that are listed right there as listed, which help determine appropriateness for physical therapy care versus less conservative interventions. Objectively, we perform a review of systems, especially determining if dermatomal or myotomal distributions are involved. As noted by Dr. Leo, some may have symptoms of double crush or dual entrapment, which we can parse through with various special tests, neural tension tests, radiologic findings, and the results of nerve conduction and EMG studies. Now, because human movements occur in a series of chain reactions and they're not in isolation, one of the most important things we can look at is the movement itself. Dr. Cowin, he kind of touched on that a little bit. So with that, we look at postural alignment to determine if there's any obvious dysfunctions, such as spinal deviation, pelvic and or sacral torsion that are typically accompanied by muscular and range of motion imbalances, and then subsequent functional limb length discrepancies that can be resolved over time if you're with the therapist who is inclined to that sort of evaluation. Now, the reason these factors are so pathomechanical is because the pattern of tone is dictated by the repetitive demand that is carried out in our daily lives and various activities or lack thereof. So it's not enough just to accept that a person has a disc herniation or pain, but ask why, or at least what are all the pathomechanical forces leading to that. This is why PT is not just like a blind workout, but is a methodical science and art combined to not only rehabilitate, but truly optimize function. And the only way this can be achieved is via progressive motor control strategies that ultimately lead to motor learning and behavioral change. And that behavioral change is that they no longer load the spine in such a harmful way while doing that particular movement, or at least that's our goal. Now, the spine acts as a crossroads for force distribution and transformation, not only from the top down, but the bottom up, which is why practically all of human movement has a transformational zone involving acceleration, deceleration, and then a return of acceleration through the spine. So it's extremely important to see the big picture and the entire kinematic chain reaction above and below the disc herniation. Now, because disc tissue is inert and non-contractile, the activity and distribution of force is largely dictated by the muscular synergies and the resultant forces on the spine. And it's very specific to that movement. So we have to be inclined to see all the multidimensional relative movements that are above and below said disc herniation. Is the segment or segments simply unstable? Is there intervertebral hypomobility or stiffness that is leading to the hinging or slowing down or even speeding up of one vertebrae on another? And then we also have to look, are there limitations in the ankle, knee, hip, pelvis that are creating a greater demand on the back? Is there periscapular weakness? Is there loss of thoracic extension? I might even pose that you could have eccentric weakness throughout the erector spinae that's causing greater load on the lumbar. So what do we do about it? We can perform manual techniques to release soft tissue restrictions, joint mobilizations and manipulations, as well as perform nerve glides and nerve tensioners to improve that musculoskeletal and neuromobility. Now, neuromuscular re-education, which has the goal of reducing symptomatic movement by redistributing and optimizing force transmission. And this all happens at that motor control level that I was talking about. Now, spinal stabilization, this should always be oriented into the greater picture like we were talking about. So it should be oriented to dynamic stability through three-dimensional movement patterns, regardless if they have a McKinsey bias or not. So you might start off with an isolated movement pattern because you're trying to reduce their pain, but the goal is always to gradually progress away from that bias and help them restore all of their movement, or else you run the risk of either exaggerating their curvatures or losing their curvatures over time. Other modalities that we can offer are traction, dry needling, acupuncture, cupping. All of these can be assisted to help, again, decompress the spine. So lastly, reductionism, which you see on the left, and isolation, even in our careers, does not offer the best service. So interplay and collaboration, kind of like you see with the twin snakes around the sign for medicine, that is offering the most optimal good. And so I highly encourage you to know your PT and make sure they reflect that high standard of care. And because the people of our community, they have every right to the best possible care and to get back to a quality life. Anyway, so that's my TED talk. Just kidding. But I'll be answering any questions if you guys have some. Thanks.
All right. Thank you so much, Patrick. Okay, everybody, we're going to move on to the Q&A portion. And thank you so much for already submitting some questions into the chat. That's so helpful so that we can just go ahead and get started. So it looks like we already addressed and answered some of the answers about the medication. So I'm going to move on to the next question. Oh,
Jen, real quick, I'll just say in case
okay.
anybody didn't log on.
Address that first then, please.
Yeah,
Yes.
so there's a question like what the insight of choice is. Dr. Leo probably is a lot smarter on this than I am, but I can tell people just for cost reasons, I frequently tell people to take a leave just because it lasts longer than straight up ibuprofen. I think it tends to gastrically be better tolerated because it's a smaller over-the-counter pill. And I always recommend, if possible, to take Tylenol 1,000 milligrams TID in conjunction with their Aleve. But remember, you have to take at least 3,000 milligrams in a day, and it usually takes about 24 hours for the Tylenol to really kick in, because it's, absorbed in the duodenum. You need to get a serum plasma level high enough for it to actually cross the blood-brain barrier. Outside of Aleve, really any NSAID is okay as long as they don't have significant comorbidities. My personal, for my neck pain and shoulder pain and back pain, I love Celebrex, but that's pretty hard to get approved. My only reason I get it, I think, is because I got it while I was in the Army. The Army doesn't give a crap about money, so they just give you any NSAID you want. But also remember, very careful with these NSAIDs. They are pretty dangerous, and see a lot of these patients who come in with renal and GI issues because they've been taking high dose anti-inflammatories. I don't know if you have anything to add, Dr. Leo.
I would agree with what you said about the Celebrex. That's the only COX-2 specific that's left on the market. Meloxicam is close. The key for getting Celebrex is if you have a patient who's on 81 milligrams of aspirin, that's the going to be the go-to drug. With any of those, you've got to periodically check renal function and make sure that they're taking them with something in their stomach to help avoid bleeding. And what you said, naproxen is longer acting, so I think that if you can go with a longer acting prep, you have a better chance at patient compliance as well.
Awesome. Okay, we did have a question from Dr. Alexa Shepard, chiropractor. She said, I have a patient with an artificial disc in his cervical spine and was curious as to why we don't see this more in the lumbar spine.
Yeah, so really the quick summary, lumbar arthroplasty is significantly technically more difficult to do. The risk is a lot higher because the vessels sit directly over the anterior lumbar spine and require a vascular trained surgeon, at least in Colorado, typically to perform the approach. There's some risk of retrograde ejaculation and anorgasmia based with anterior surgery, which we used to just kind of blow off on women, but now it's like, hey, that's actually a real problem. So we do a lot less of that. So it's technically more difficult. And also there's more load bearing in the lumbar spine. So there's some theoretic increased implant failure risk. So all those things together really make it much more uncommon.
All right. Dr. Troy Curtis is asking, what information is most helpful for you to receive when we refer a patient to you? And before Dr. Rumley answers, I will say as a side note, all of you have my direct email address. If there's ever a stat referral or any referral issues, please reach out to me directly. I will take care of everything very instantaneously. And then Dr. Rumley.
Yeah. So with referral, honestly, most of it is how long has it been going on, and really, ideally, they've done some physical therapy for 6 weeks, maybe even gotten an MRI before they come for an orthopedic spine surgery side. When it comes to pain management, chiropractics, and physical therapy, I mean, really, we do such a significant evaluation on the patients when we talk to them that a lot of times, if the referral doesn't like come through or whatever, I'll go back and make sure I didn't miss anything because the patients usually tell me most of what I need. So really, I mean, it may sound silly, but I just need a name.
And or reach out to me for any stat referrals, assistance, etc.
Yeah, 100%, always. Yeah. Or me. I mean, you can
Yeah.
call me. Also, like the other thing I would say is a lot of providers, I mean, the medical community we're in, one of the nice advantages I have at CSO is I have all these subspecialties plus a couple more that are within the walls of our building that I can collaborate very easily. But this extends to everybody in the community. This is why we legitimately give our cell phone numbers, is if you have a question, just text or call. Like, I mean, it should be that much work Should I do it? Yes. The answer is yeah. Just reach out.
And I'm happy to provide those for you guys after this. Okay, we have a question from Dr. Leach. Are there any opinions about how to identify discogenic and or vertebrogenic sources of axial spinal pain, both by physical exam and interventional approach?
I'll say real quick from the spine side, classically, vertebrogenic pain tends to be worse with forward flexion, but also they can develop something called micro or vertical instability pain. That's really by history. They say that quick motions, things like that, make their pain worse. They may develop radiculopathy, whatnot. And we actually did a talk, which I think is available. My last talk is about back pain and when does it matter? And it really deals with this topic of discogenic back pain and when is it actually a problem, and a little bit on herniations. Facetogenic pain, there's Kempsine, extension. Honestly, anything can be facetogenic back pain. So I don't know, Dr. Leo, do you have any, or Corwin, do you guys have any things that you pick up for facetogenic pain?
Well,
Or Patrick? Patrick, you probably pick it up all the time too.
so for me, a good exam, having them sit, stand, watch them walk. I have them flex and extend. I check the segmental function. A pathognomonic for if you have extension and rotation and that causes increased pain, that is supposedly pointing to facetogenic pain, and that the SI joint can mimic L4-5, L5-S1 in the same distribution. So don't forget to check there as well. Check for a sacropelvic torsion. And those are the places you're going to look for facetogenic. So for the front of the spine, vertebrogenic or discogenic, and that's actually now starting to be a question of which is really which, is going to be more sitting, forward flexion, bending forward. That's another one. Does it hurt more when you bend forward or when you stand back up? If it's bending forward, it's probably more discogenic. And if it's when you're standing back up and leaning back, it's more facetogenic. And then there's all that stuff in the middle we just talked about with discs and pushing on nerves and stuff.
All right. Were there any other additional questions? I did I miss any in the chat? I think I got all of what was in the chat.
Yeah,
I think that's
from Dr. Leach, your second part of that question was your interventional approach. I think both Dr. Rumley and Dr. Leo both touched on that, and the exam is what it comes down to, being able to identify that. As far as interventional on the ultra conservative side, being the chiropractic aspect, looking at things like treating the multifidi, whether it's through dry needling approaches or and really multifidus, the only way to get to the multifidus is with a needle. And so on my end, looking at using a dry needle, Dr. Leo, are you injecting things like multifidus for any type of spastic issue or but yeah, I think cleaning up some of those stabilizing type musculature is where what I'm looking at. Yes, the joint mobs also help kind of reset some of that joint mobility if we're going to get really focal, but usually it's the muscular component.
There is actually now if you can show that this is multifidus weakness, there is a multifidus percutaneous stimulator that stays in for a period of time and works the muscles and tries to recover and stimulate the muscles. So that is an option as well for that.
Is that stimulator Patrick Cook screaming at him in the therapy room, telling them to get their butt moving?
I don't have to plug him in.
That's exactly right. Yeah, they always say a lot of patients joke about me like driving them like a slave or whatever. But yeah, I'd say I just echo kind of a combination of everything that Dr. Leo and Dr. Cowin said. Yeah, we try to use that multimodal approach using all the tools in our tool bag. So from the exam itself, discerning kind of like what movement patterns are aggravating it. Then from a treatment side, like Dr. Cowin said, we could use dry needling, especially if it's like a you can test for segmental hypomobility and just kind of see if their lumbar spine is moving at all. And if that's not the case, then typically we would go to something like dry needling and then follow that up immediately with joint mobilizations, passive intervertebral movements, which is like this kind of multiplanar gapping of the facet joint. And you can literally do that at the segmental level. And then you follow that up with active movement that requires that particular motion.
All right. We had another question from Guardian Medical. Shout out Guardian Medical. Thank you. Does bilateral transforaminal injection help with interventional diagnosis for discogenic pain? And what is sensitivity generally for this procedure? Discogram anymore?
Yeah,
Sorry,
I
I
know.
was just reading.
So I can tell you my approach is changed a lot. So for discogenic back pain, I force the patients till they can't stand it anymore to keep doing physical therapy and chiro. But the big difference with discogenic back pain with physical therapy and chiro is to not mobilize the segment to allow it to stiffen, because it's that instability, I believe, that causes a lot of their pain. As far as the bilateral transforaminals for discogenic back pain, there's a difference between discogenic back pain, meaning it's coming from the inflammatory mediators of a herniation, because I mean those are ridiculous symptoms. Discogenic back pain, we're really talking about, in my opinion, instability. And in instability, I don't think there's any real good way to make them feel better with a needle. There is some early stuff, and Dr. Leo had mentioned with some of this allograft nucleus pulposus injections, maybe for select patients that might be okay. But I'm actually now a believer in discograms again, because understand they weren't taken off the market because they weren't really good at predicting and diagnosing discogenic pain. They were initially kind of poo-pooed on because at the control level, we saw a lot of disc degeneration from high pressure, large bore needle discogram injections. A paper in 2019 showed the patients with low pressure, small diameter needle discograms have no increased disc degeneration at the control level at 5 years. And we'll see what it is at 10. But for me, by the time I'm trying to diagnose surgically, if I need to treat discogenic pain, I try to get a discogram. But most insurance providers will not pay the facility fee, so it's hard to get the sedation for it because discograms don't feel good.
They are one of the more uncomfortable things that we do.
Yeah. Yeah, for sure. But yeah, discogenic pain is its own, like it's the Pandora's box. It's back pain. When does it matter, right? So yeah, I encourage any questions about disc stuff. You can either text me, ask me, or that was the last one of these I led, because yeah, this is a common question that nobody has the right answer to. Dr. Leo and I even argue about it sometimes.
Well, we've got the question of, is it vertebrogenic, and now there's a procedure to ablate the vertebrobasilar nerve.
Yeah.
And then that supplies the end plates and the rest of the vertebral body, not the disc. And there seems to be pretty good relief with that for a lot of people.
Yep. Agreed.
So that's another question: is discogenic pain really vertebrogenic pain being experienced by tension on the end plates? So again,
Yep.
we can talk that one over with one of these bottles of wine.
Okay.
All right.
Were there any additional questions from anyone? I guess
Right.
that's a no. Going once. Okay, guys. Well, I want to respect everyone's time, so please cut me off if you have a question, but if not, I'm going to roll with our little recap here. I just wanted to thank everybody so much for being a part of this. It's such an honor to provide this type of CME and just overall networking to our community. So thank you guys, especially on World Spine Day. So thank you for helping us celebrate World Spine Day. First and foremost, you will receive your CME information tomorrow. I will send that to everyone via email, just like I sent the Zoom link. If for some reason you do not receive the email with the CME info, please just email me. Maybe there was some technological error, so just email me, but you will get that tomorrow morning. Secondly, I wanted to just take this opportunity while I had everyone in person to let you guys know, if you didn't already receive my email, that obviously, as you can see, we have rebranded our practice. But I do want to let you guys know that while we did rebrand our practice, we have not been bought out. We have not changed ownership. We are still locally, privately, and veteran owned. We've been locally and privately owned for 30 years. Nothing about our company will change. We just needed a new look and feel to bring us into 2024 and beyond. So
Why is that, Jenna? What was wrong with the old logo?
I thought it was ugly.
Exactly.
I cannot appropriately say in front of this many people, but anyway, but yes, I hope you guys appreciate and like our new logo. If you have questions regarding that, please ask me. I'm happy to answer. But if you start seeing our paperwork and our info and all of that with the new logo, that is why. But again, absolutely nothing else has changed. We're just trying to serve our patients and our preferred provider referral sources better. So once again, thank you guys. I don't think I'm forgetting anything else, but thank you everyone. We will be doing 2 Spine and Wines a year now. So look for our next Spine and Wine, probably April or May of next year. If your colleagues want to be added to our email list, tell them to email me. You guys all have my email. So also, if you have additional questions after this lecture, please send them to me. I will get them answered for you. And if you have questions about referrals to our surgical team, our pain management team, our chiropractic team, or our physical therapy team, again, please email me. I will help you guys with all of that. So thank you everyone again for being here, and salud.